We have a few folks putting in where they're calling from. You can let us know where you're calling in from, and we'll get started here. So I'd like to welcome everyone to our SADS Foundation Living with SADS webinar tonight on pregnancy with an inherited arrhythmia. So thank you for joining us. I'm Marcia Baker, the program director with the SADS Foundation. It is my pleasure to introduce our presenter, Dr. Lisa Albertini, who is volunteering her time tonight from Canada. Dr. Albertini graduated from medical school in Italy and completed her cardiology residency at the University of Parma in Italy. Dr. Albertini completed a Master of Science in Cardiac Electrophysiology and Pacing in Milan, Italy. And then she pursued her interest in advanced management of cardiac arrhythmias, completing a clinical fellowship in adult cardiac electrophysiology at Toronto General Hospital in Canada, and a clinical and research fellowship in inherited arrhythmias and cardiomyopathies. She is currently a cardiology staff member at Mount Sinai Hospital in Toronto and is part of the University of Toronto Pregnancy and Heart Disease Program with a specific focus on arrhythmia management in pregnancy. So following her presentation, you may ask Dr. Albertini questions by typing them into the chat feature that you'll find at the bottom of your screen. This webinar is being recorded, so please mute yourself during the presentation and the question and answer session. And the link to this recording will be sent to all of you in a few days. Now I'll turn the microphone over to Dr. Albertini.
So thank you, Marcia, for this nice introduction. It's really a pleasure to be here with you tonight and discuss this sensitive topic. I think it's a very relevant discussion. It's a very important topic because people with inherited arrhythmias are often young. And thanks to family screening, we are identifying more and more young family members who at some point will reach childbearing age, and so they will seek to start a family. So I think there are many people who are actually interested in this, and they have doubts and questions, and they want to know more about this. So thank you for the people who are joining us tonight, and also to the people who will watch this webinar later on. So I'm gonna start my presentation. Planning a family, planning to have a baby is of course very exciting, and it's such a very special moment in everybody's life, right? But in people with the inherited arrhythmia condition can also brings many doubts and fear and questions. And when people with inherited arrhythmia condition comes to us for this reason, planning to start a family, they have two very important questions. The first important question they have is, will my baby have the disease? And the second question is, can I get safely to a pregnancy? So tonight I will try to share with you what we know about transmission of inherited arrhythmia conditions and what we know about outcomes of pregnancy in women with inherited arrhythmia conditions. Of course, every patient is different, every situation is different, and we can't generalize, but at least we can give to the audience an idea of the implication of having a pregnancy in women with inherited arrhythmia conditions. So I want to emphasize that it's really that this stage of family planning is very important. At this stage of planning, we can see the patient preconception counseling before getting into the gestation. And it's important because we can, first of all, provide information about what to expect with the pregnancy. And it's also an opportunity for us to optimize treatment and plan intervention if it's needed. So of course, so as doctors, we like to plan everything, to have everything under control, but in this matter, in pregnancies, we can't control everything, right? So sometimes women are referred to us for preconception counseling, and they show up and they say, you know, I have a good news, I'm pregnant. And so then we have to deal with it. But the good news is that most of the time, in most of the cases, if there is a clear diagnosis and if there is a proper treatment and if the woman is compliant with the medication during pregnancy, most of the time pregnancies are uneventful in women with inherited arrhythmia conditions. So it means that there are no adverse events for both mom and the baby. So I will start with the first question I was mentioning: will my baby have the disease? So we are discovering the last 20, 30 years, we have been learning a lot about genetics of inherited arrhythmia conditions. And every day there is new research published about genes causing inherited cardiac conditions or new mutations. But we still don't know everything, and we still have a lot to learn. So for some diseases, such as long QT syndrome, for instance, we can identify genetic cause of the disease in up to 80% of the patients. It means that in 8 out of 10 patients who present to the clinic for clinical diagnosis of long QT syndrome, in 8 out of 10, we will be able to find a genetic mutation. For other diseases, such as, for instance, Brugada syndrome, we can identify a genetic mutation only in a minority of patients, generally in 20 to 30% of the patients. So the important point is what does this mean? So the rest of these patients have no genetic predisposition for the disease, and the answer is probably they do. They have a genetic cause of the disease, but we just don't know about it, or we don't know how to find it yet. And this is important because when we know the genetic cause of the disease, when there is a familiar genetic mutation identified, we can actually give information about transmission of the disease. But when there is no mutation identified in the family or in the individual, we can't provide information about transmission of the disease. So, for instance, a common type of transmission of genetic mutation is the autosomal dominant transmission. That means that, so usually all of us, we have 2 copies of every gene. And when there are a mutation transmitted with an autosomal dominant pattern, means that one abnormal copy of the gene is sufficient to actually cause the disease. So if, for instance, we have dad who is affected, so he has one abnormal copy of the gene and one normal copy of the gene, and mother is healthy, is unaffected, has 2 normal copy of the genes, their baby will inherit for sure a normal copy of the gene from mom, but will have a 50% chance to get the abnormal copy of the gene from dad. So they will have a 50% chance to have an affected child. Of course, in genetics, nothing is simple and nothing is black or white. There are many gray zones. For instance, sometimes we identify VUS, which are variants of unknown significance. And these variants, usually, we don't really know the meaning of these variants. We know these are different from what we normally see in the normal population, but we are not sure if they are actually causing disease or not. And so even if a patient has a clinical diagnosis of inherited arrhythmias, but is just a carrier of VUS, we can't really provide the transmission of the disease. So that's why at the stage of family planning, it's very important to meet a genetic counselor, because a genetic counselor can really provide education and can really provide information about genetic transmission of the disease. And also can offer a way to do early genetic testing for the baby, which is usually done through cord blood at the time of delivery. And so with the genetic counselor, advanced fertility options can also be discussed. So nowadays there is in vitro fertilization, and there is the option of pre-implantation genetic testing and embryo selection. So this is something that can be discussed. Of course, again, it's a very complicated topic and matters, and there are many things that needs to be taken into account. First of all, costs, significant costs associated with these techniques. but many other considerations. And for instance, variable penetrance. That means that not every genetic mutation will manifest in the baby. So some babies can have the genetic disease, but not present clinically the disease. So there are many considerations that needs to be done. So at the stage of family planning, we are still at this stage. Other than providing information, we can actually getting ready for the pregnancy and, for instance, review medication safety for pregnancy and lactation. Most of the medication we use for inherited arrhythmia condition, especially beta blockers, can be used in pregnancy, but there are some, for instance, ACE inhibitor, which are used for heart failure, which are contraindicated during pregnancy because this medication can be harmful to the baby, and so it needs to be stopped. And another very important point also that needs to be discussed with the women before the gestation is compliance with medications. It's a very, very important point because often women are really scared about taking medication during pregnancy. They are concerned about adverse effect of the medication on the baby, and sometimes they just don't want to take anything. But medications, and especially beta blockers in inherited arrhythmia condition, are essential during pregnancy, and stopping the medication during pregnancy can actually increase the chances to have arrhythmia recurrences, cardiac events during pregnancy. So this is a very important point that needs to be discussed. And of course, we need to share a plan with our OB colleagues during the pregnancy and gestation. And then moving on to the next question, can I get safely to a pregnancy? So I'm gonna show you what we know, the information we know we have about outcomes of pregnancy in inherited arrhythmia conditions. I will start with long QT syndrome. I'm gonna start with long QT syndrome because it is the most common inherited arrhythmia condition. This disease was initially described in 1957, so more than 60 years ago, by these two gentlemen, Jervell and Nielsen, who described a severe form of disease associated with the congenital death and mutism and the risk of sudden death. So long QT syndrome is common, and the prevalence is up to 1 every 2,000 live births. Many subtypes of this disease have been described, but long QT syndrome type 1 and 2 and 3 are the most common. So this disease is characterized by abnormal cardiac repolarization, which basically is expressed by abnormal QT interval on the 12-lead ECG, and is characterized by arrhythmia-mediated syncope, that means fainting, so sudden fainting, which are caused by ventricular arrhythmias, and sudden death, again caused by life-threatening ventricular arrhythmias. And these events are known to have specific triggers, such as, for instance, swimming or sudden awakening during the night for long QT syndrome type 2. So the first data about pregnancy and long QT syndrome came in 1998 when they published this study, and they reviewed 400 women with long QT syndrome who had pregnancy. And for the first time, they described that the postpartum period is actually a time where there is a significantly increased number of cardiac events. So again, faintings and sudden death. And at that time, beta blockers, we know nowadays that beta blockers are the cornerstone of long QT syndrome. And so women, and generally speaking, people with long QT syndrome needs to be treated with beta blockers. At that time, only a minority of the patients were treated with beta blockers. But even then, they were able to show that beta blockers are actually protective even during pregnancy and postpartum, and beta blocker were really reducing the chances to have adverse cardiac events from 1 out of 50 in absence of treatment to 1 every 2,500 for women who were taking the beta blockers. So they were really protective. And so later on, this was 10 years later, they published another paper that looked at the clinical course of long QT syndrome women from age 15 up to age 41, looking also at the time before conception and the time of gestation and the postpartum period. And they were able to show, as you can see here in this tall bar, I don't think you see probably you don't see my arrow. So anyway, this tall bar shows you how during all this time from age 15 to age 41, the postpartum period was actually the time with a higher risk of adverse events. And so probably many of you are asking themselves, why is that? Why is this time so risky for long QT syndrome women? And so there are multiple theories, so multiple hypotheses have been postulated, and some of these includes, for instance, hormonal effects on the adrenergic sensitivity, or also lifestyle issues such as, for instance, wakening suddenly during the night to breastfeed the newborn, and so there are probably multiple components to cause this factor. And so, as you can see, in the postpartum period, there is an increased risk of life-threatening events, up to 4.1-fold increased risk. And so in this paper, they looked specifically at the type of long QT syndrome, and they were able to show that the same trend was observed for every type of long QT syndrome, but especially in long QT syndrome type 2, there was a significant increased risk. And again, beta blockers, even in this study, was beta blocker usage during pregnancy and postpartum was protected and was able to reduce the chances to have an events from 3.7 events per year to 0.8 events per year. So how we treat pregnant women with long QT syndrome? Again, beta blocker is mandatory during pregnancy and postpartum. Basically, there is only one beta blocker, which is contraindicated in pregnancy, which is atenolol, but all the other beta blockers can be assumed by the pregnant woman during pregnancy. The most common side effect is fetal growth restrictions. That means that the baby can be a bit smaller. Usually, it's something modest. It's usually we tell the patient 200, 300 grams. It depends also on the dose of the medication, but it's not usually clinically relevant. Other side effects of beta blockers during pregnancy are so the baby can have a low blood sugar at the time of birth, and can also have low heart rate at the time of birth. So that's why babies are usually screened if their mom was taking beta blocker during pregnancy, but these effects are usually transient and are not a clinical issue. So beta blockers should be continued during pregnancy and postpartums and not stopped for any reason. So as we know, patients with long QT syndrome must avoid QT prolonging drugs, generally speaking, and this is relevant for pregnancy because, as we know, in the first trimester, pregnancy is often causes nausea and vomiting. And so many medications that we use for nausea and vomiting are actually QT prolonging drugs. And so attention should be paid to that. And also for the postpartum period, as we know, unfortunately, sometimes depression may occur, right? And so antidepressant anxiolytic drugs can cause QT prolongation as well. As we were saying before, genetic testing can be offered usually through cord blood testing if there is a familiar mutation identified. Usually regarding the delivery, cardiac monitoring is not necessary unless there is history of recurrent events. And then the baby can be screened with an ECG and can be started with beta blockers if needed. And so, of course, the baby should be screened by pediatrician with experience in inherited arrhythmia conditions and long QT syndrome. So I just want to mention that long QT syndrome may manifest in the baby when the baby is in utero, and can manifest with low heart rate or AV block, or can also manifest as ventricular arrhythmias. So this can be diagnosed when the baby is in utero through echocardiography or through fetal magnetocardiography, which is another non-invasive technique. And this is relevant because if the baby has ventricular arrhythmias, of course, we are talking about severe form of the disease. So if the baby has ventricular arrhythmias in utero, the baby can be treated with medication through the mom. Okay, so I will move on now to Brugada syndrome. Brugada syndrome is an inherited arrhythmia condition that was initially described by these two Spanish cardiologists, Pedro and Joseph Brugada, in 1992. Brugada syndrome is characterized by a specific pattern on the ECG called the Brugada pattern in people with the structurally normal heart. So in people with no abnormalities, no structural abnormalities. This pattern on ECG can be spontaneous or can be provoked by medications. And we use that actually as a drug challenge to diagnose Brugada in borderline cases, and can be triggered in specific scenarios such as high fever. So these patients present with, again, with faintings and cardiac arrest secondary to ventricular arrhythmias. So we didn't have many data about Brugada syndrome in pregnancy because usually Brugada syndrome is more common in male, and also is more severe in male compared to women. And so the first study that actually looked at the outcomes of Brugada patients during pregnancy was published in 2014 in this Spanish journal. So they looked at 200 pregnancies in around 100 patients. And they were able to demonstrate that the event rate was not increased during pregnancy. There were no arrhythmic deaths, so there were no sudden deaths secondary to ventricular arrhythmias. And there were no, and the outcomes of the babies and the fetal outcomes were similar compared to the general population. Brugada syndrome in pregnancy, of course, if we have a familiar mutation, we can test the baby. And if the baby comes out to be a carrier, the mutation, we can give recommendation.
This Brugada syndrome was only like, no, it was 1992.
Yeah. Yes, so long QT syndrome was identified much earlier compared to Brugada syndrome. Regarding Brugada's management in pregnancy, so Brugada patients, there are different degree of severity in this type of syndrome, and we have patients who are completely asymptomatic and patients who have recurrent ventricular arrhythmia. So severe cases of Brugada syndrome needs to be implanted with ICD, with cardiac defibrillators. This, of course, ideally should happen outside the pregnancy, and that's why we want to see the patients at the stage of family planning, because interventions such as cardiac devices implantation with pacemaker defibrillators involve use of X-ray, and so it's not ideal during pregnancy. It can be done if necessary, and nowadays there are strategies to reduce X-ray exposure, but ideally should be done outside the pregnancy. And the same is also for ablation of arrhythmias, ventricular arrhythmias, or ablation in general. It can be done in pregnancy, minimizing the X-ray exposure, but ideally should be done before the gestation if there is the need. So Brugada syndrome, usually vaginal delivery is not contraindicated. Cardiac monitoring during delivery is recommended only if there is a significant history of arrhythmias during pregnancy, or if there is spontaneous Brugada pattern on the ECG. Some caution should be used with the epidural anesthesia, with the regional anesthesia, because some medication that they use for the anesthetist used for epidural anesthesia can actually exacerbate the Brugada pattern. So there should be specific attention to the choice of medication. The baby can be screened with an ECG, but generally speaking, Brugada syndrome rarely present in infancy and childhood. There are rare cases of Brugada syndrome with arrhythmias in children. I will move on and talk about arrhythmogenic right ventricular cardiomyopathy. So arrhythmogenic right ventricular cardiomyopathy is a word that actually basically include a group of cardiomyopathies which are similar presentation, which is actually a tendency to develop ventricular arrhythmias, sometimes preceding structural changes of the heart muscle, sometimes showing up at the same time of structural changes of the muscle. So it was initially discovered it was initially thought to be a disease only of the right ventricle, and that's why it's called arrhythmogenic right ventricular cardiomyopathy. Abnormalities of the muscle in the right ventricle were identified, especially fibrosis, that means scar tissue in the middle of the heart of the muscle of the tissue of the heart, which was actually which is actually the cause of the ventricular arrhythmias. Most recently, actually, has been found that this disease is actually affecting also the left ventricle and is actually a biventricular disease. So we know that ARVC is associated with an increased risk of sudden cardiac death, particularly during exercise. And we also know that ARVC can be actually, so the progression of this disease can be accelerated by intense exercise, excessive endurance exercise, and can actually cause ARVC-like phenotype, ARVC-like manifestation, even in absence of genetic abnormalities. And we know actually there are many cases of professional players, such as this one. This is a cricket player, British cricket player, who were diagnosed with ARVC at some point in their career. Some tragic events on the field, life-threatening cardiac arrest in the field. It is always astonishing, right, how these professional players were screened and they have multiple checks every year. They just have cardiac arrest on the field. But ARVC can be subtle sometimes and can really present with ventricular arrhythmias, even if there are minor structural abnormalities of the heart. And why is this relevant for our topics tonight? It is relevant because pregnancy is somehow a cardiovascular stress, right? Because during pregnancy, there are many cardiovascular changes in the woman. So there is an increase in the blood volume, in the plasma volume. There is an increase in the heart rate. There is a slight enlargement of the cardiac chambers to accommodate this increase in blood volume. And so the question is, are women with the ARVC at risk during pregnancy and postpartum because of the reason I just said? So this question was answered by this paper published by a European group who analyzed women with the ARVC mutations coming from Denmark, Norway, Sweden, and Finland. And they looked at their outcome years after the pregnancy to see if women who had babies compared to women who didn't had different outcomes even after the pregnancy. And they were able to show that women who had pregnancies compared to women who had no pregnancies had similar outcomes in terms of arrhythmias. So it means that women who had pregnancy did not have more adverse cardiac events, more sudden death or more faintings. And the same was also for even looking at the number of pregnancies. So they look at the women who had 1 or 2 or 3 pregnancies, and there was no difference. So this was a very important information. They also looked at the imaging data. So they looked at the echocardiograms and the MRI, the cardiac magnetic resonance of these patients. And they compared the women who had babies and women who had no babies. And they looked at the characteristic, the imaging findings were actually similar. It means that the women who had pregnancies did not have worse did not have deterioration, higher degree of deterioration of the right ventricle. So the pump function and the size of the right ventricle was similar in the 2 groups. They also looked at the outcomes during pregnancy of women who had the genetic mutation, the ARVC genetic mutations, but they had no signs of the disease at the time of the pregnancy. So they were just carrier of the genetic mutation, but had no clinical diagnosis. And they were able to show that these women had no pregnancy-related ventricular arrhythmia. So they had good pregnancy outcomes. So there were other studies about ARVC and pregnancy, but and these are basically the main points, the main conclusion, that events during pregnancy and delivery and postpartum are rare. Ventricular arrhythmias may occur during pregnancy, but the chances to have recurrent ventricular arrhythmias are higher in women not taking medication, not treated for arrhythmias during pregnancy. Heart failure, that means fluid retention in the lungs, in the extremities, which may cause shortness of breath or peripheral swelling, edema, may occur during pregnancy, but this is more common in women who were known to have major structural changes in the RV before the gestation. So worsening of the size and the function of the right ventricle during pregnancy is actually quite rare. So beta blockers, again, is the cornerstone therapy for ARVC2. And so beta blockers should be continued during pregnancy, and some experts suggest actually a beta blocker therapy in all patients with ARVC. In these studies about ARVC and pregnancy, the rates of C-section was not different compared to the general population. So vaginal delivery can be an option in women with ARVC, but C-section may be recommended if there is a high history of heart failure. So ICDs are implanted if there are major arrhythmic events, or if there is a severe dysfunction of the ejection fraction, severe low reduced ejection fraction. It means a reduced pump function of the heart. So in these cases, these patients usually are implanted with an ICD, and again, ideally this should happen before pregnancy. Cord blood testing is an option when there is a known familial mutation. Again, C-section is an option if there is a history of heart failure. Otherwise, unassisted vaginal delivery can also be an option. Cardiac telemetry, and cardiac telemetry sometimes may be a limiting factor because not every hospital has offered a cardiac telemetry in women during labor. So it's not possible in every hospital. So when telemetry is recommended, usually the pregnancy and delivery should happen in a tertiary center, center with expertise in this type of diseases. The baby can be screened at birth for ARVC, but usually the clinical manifestation of ARVC occurs after the age of 10, is not really so common in children. I'm gonna now talk about catecholaminergic polymorphic ventricular tachycardia, or CPVT. So CPVT is a very rare inherited arrhythmia condition. So the prevalence is 1 in 10,000 individuals, live births. So CPVT is characterized by ventricular arrhythmias, so life-threatening arrhythmias in individuals, in patients with normal heart and a normal ECG. So it's a very tricky disease. And the hallmark of this condition is actually ventricular arrhythmias triggered by physical exertion, increasing physical exertion, or emotional stress. And so you may think about pregnancy and CPVT and think, okay, pregnancy and the labor, it's a very stressful time. So the question is the same. Are women with CPVT at risk during pregnancy and the postpartum? So we didn't have many data until 2019 because actually, again, CPVT is a rare disease, right? So in 2019, this study was published. They reviewed the outcomes of 96 women with CPVT who had 228 pregnancies. And they were able to show that there was no difference in the cardiac event rates during pregnancy and postpartum compared to the non-pregnant period. They described some cardiac events. They described 7 cardiac events, but at least 6 of these women were not taking medication during pregnancy. CPVT is treated with beta blockers, non-selective beta blockers, and flecainide, which is an antiarrhythmic drug, and both medication can be given during pregnancy, should be continued during pregnancy. Also, the adverse fetal events, such as miscarriages, stillbirths, or fetal growth restriction were actually comparable to the general population. So the main points about management of CPVT in pregnancy are, again, to continue beta blocker and medication through the pregnancy. The dose of the medication, this is another important point. During pregnancy, sometimes we need to increase the dose of the medication, or we need to increase the frequency of some administration of the medications. And this is because during pregnancy, again, there are many changes in the woman's body, and there is also an increase in the metabolism, in the liver metabolism, and in the kidney metabolism. So it means that sometimes the dose we use outside of the pregnancy may not be enough. We might need to increase the dose, or again, increase the number of administration. So sometimes we need to reassess and change this during the pregnancy. So of course, labor and delivery is challenging in these women because it's a very stressful time, right? The data from the studies we have showed that delivery can go well and can be uneventful if the woman is stable, is treated with medical therapy and is stable on that therapy. Vaginal delivery can be offered. Early epidural should be recommended in all these patients because we want to minimize the pain during the labor. So it should be offered really early during the time of labor and delivery. And usually these women, an assisted second stage is also recommended. It means that the time of pushing at the end during the labor, at the time of pushing, usually the obstetrician helps taking the baby out with some specific tools. Again, to minimize the stress related to the delivery and the time of pushes. I'm gonna end with some slides about hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is a disease characterized by increased thickness of the heart muscle. This increased thickness sometimes can also cause obstruction to the blood flow. We call this obstructive hypertrophic cardiomyopathy. And so the data we have in hypertrophic cardiomyopathy is that we may have complication during pregnancy, and most common complications are arrhythmias, especially atrial fibrillation is the most common arrhythmia, or heart failure. If this occurs, usually It happens in the last trimester of postpartum. But most of the pregnancy, the majority of the pregnancy are uneventful, and maternal mortality is low. So worsening of symptoms, especially heart failure, has been described in up to 30%, but usually it happens in women who already had heart failure before pregnancy. Preterm delivery has been observed in up to 26% of the patients. No difference has been described in obstructive versus non-obstructive hypertrophic cardiomyopathy. So again, beta blockers are used in hypertrophic cardiomyopathy to treat outflow tract obstruction, to prevent heart failure, and to treat arrhythmias, and again should be continued during pregnancy. I was mentioning atrial fibrillation in the most common arrhythmia in hypertrophic cardiomyopathy during pregnancy. Usually is not well tolerated, and so an electrical cardioversion may be considered if it happens. These women are at risk of developing clots and stroke, and so they should be treated with anticoagulation during pregnancy if they develop atrial fibrillation. Low-risk women may have a spontaneous labor and vaginal delivery. High-risk women, in this case, planned delivery and C-section may be recommended. Attention should be paid to epidural anesthesia if there is significant obstruction to the blood flow. But there are reports also that if done with the proper taking, the proper measurements, it can be done in these women. So I'm gonna move towards conclusion of this presentation. So I think the main points for all these diseases we just talked about is that preconceptual, sorry, there is a mistake here. Preconception counseling is very important to discuss need of interventions and to provide information to the patient or the couple. Compliance with the medication, I stressed this concept multiple times, is essential to avoid arrhythmia breakthrough and adverse events during pregnancy. During pregnancy, we might need to review medication dose and frequency of medication administrations. So follow-up should be done in a cardio B clinic with experience in arrhythmias or inherited arrhythmia conditions. And of course, we work together with our OB colleagues who have their own high risk, especially high risk pregnancy clinics. And so, for instance, we have a very good collaboration with the OB in our hospital and the Mount Sinai Hospital in Toronto. So I think that's it. So thank you for your attention. Maybe it was a bit long. I hope I didn't. It wasn't too boring for you.
Thank you, Dr. Albertini. It was very enlightening, very comprehensive. So we appreciate your time. And I just posted a request for any questions for Dr. Albertini to post those in the chat. And so we have our first one here. What is recommended to manage nausea and vomiting during pregnancy in women with long QT, since many of the meds are on the list of drugs to avoid?
Yeah, so that's a very good question. So usually we really don't want pregnant women with long QT syndrome to take Zofran, ondansetron. Gravel can prolong QT syndrome, but looks less bad compared to ondansetron. Diclactin can be used during pregnancy. Yeah.
Okay, thank you. Any more questions? You can type them in the chat feature at the bottom of your screen if you find that. Okay, thank you. Here's one from Mitchell. Is there any data on postpartum events with CPVT patients?
There are no specific data showing a higher risk of events in postpartum. So no, the answer is no. Of course, most of the concerns are related to delivery, right? Because delivery is the most stressful time with the pain and so on. But all the data show that if women are treated with flecainide and Nadol or other beta blockers and are stable on those medications and did not have arrhythmia breakthrough before the pregnancy or during pregnancy, even during delivery and labor, there are no events and there are no arrhythmia recurrences.
Okay, thank you very much. Any more questions? Are more frequent OB or EP visits needed during pregnancy?
Of course, it depends. It depends how is the patient, if the patient is stable or not. But for sure, usually more OB appointments or more OB checkup are needed during pregnancy. They need to check to repeat the ultrasound, to check the growth of the baby. Then they need to check many things. So yes, the answer is probably OB. Of course, if there are women who have recurrent events during pregnancy, we might need to see them more often or arrange more tests or stress tests or yes, we might need to see them often as well.
Okay, thank you. Can maxillatine be taken during pregnancy? From Jackie.
Yeah, so that's a good question. The answer is we don't have many data actually of maxillatine during pregnancy. From what we have is not, so we don't have data showing that it really causes adverse effects and events. We know lidocaine, that is a similar medication usually given IV, cause no issues during pregnancy, has been used a lot as anesthetic. So we have a lot of data for lidocaine, which is a similar drug compared to maxillatine. Generally speaking, there are a few reports of ventricular arrhythmias treated with this medication during pregnancy. So, the safety data of medication during pregnancy comes from animal studies, and they come also from experience, right? So medication have been used a lot in pregnancy, give us more information, but medication that are being used rarely during pregnancy, we don't know much. So the answer is we don't have many data reporting use of maxillatine in pregnancy, but the few data we have did not show severe effects on the baby.
Okay, I have a question from John. Is severe hypertrophic cardiomyopathy a contraindication for pregnancy?
Of course, it depends really. It depends really on the patient. If there is a very advanced stage of disease, and for instance, hypertrophic cardiomyopathy can, severe form of hypertrophic cardiomyopathy can really evolve with severe LV dysfunction, can be challenging for pregnancy because these women can really have severe heart failure or can have cardiogenic shock during pregnancy. I don't want to say that is contraindicated, but might be a very high risk pregnancy with high risk of complications. There are other scenarios, there are other conditions, for instance, pulmonary hypertension, where we really discourage pregnancies. In this case, probably we may say that the pregnancy may be at high risk of complications.
Okay, thank you. Let's see. How often do these conditions first present during a pregnancy versus prior to?
That's an interesting question. So for instance, women with long QT syndrome, it's a type of condition that, may be well, for years and nothing happened. And then pregnancy may be a scenario, and postpartum may be a scenario when they may present with the first event. Because as we saw in the previous slides, postpartum is a specific time with a higher risk of events for women. So yes, in some cases, yes, pregnancy and postpartum can be the first time, the first presentation. For other diseases such as, for instance, CPVT, usually these patients present symptoms before pregnancy, CPVT or HCM usually are diagnosed before the pregnancy.
Thank you. Can symptomatic CPVT patients have a successful pregnancy?
Absolutely. Again, it's a matter of treatment, of proper treatment. I've seen patients, high-risk CPVT, who had multiple events and they have multiple shocks from their device, from their cardiac defibrillator, who finally were treated with the right combination of medication that nowadays usually it's again flecainide and non-selective beta blockers such as nadolol. And these patients on the right combination and dose of medication had really uneventful pregnancies with no events even during delivery, and yes, they have really no issues.
Okay, thank you. Any more questions? We're almost to the bottom of our hour here. Well, I want to thank Dr. Albertini, and I want to thank all of you for participating and putting through questions.